Hello and a good evening and a warm welcome, ladies and gentlemen, here live from Paris. My name is Philipp Nicolai. I'm the head of the Interventional AV Valve Department at Bosch Health Campus in Stuttgart. Within the next hour, we will have a deep dive into current treatment options and into diagnosis of tricuspid regurgitation. And I'm not alone here. I'm together with my dear colleagues and good friends, Holger Priebe-Brämer from Witten and Marcel Weber from Bonn University Hospital. So we will be, thanks for joining us, we will be interactive. So if you have any questions, so don't hesitate to ask the question. We will also have polls within the hour. So it's good to see you here, it's good to be here. And I think the time is running. We will start with the first presentation. The first presentation is about prehab and about patient findings. So prehab is a big topic in the US, and it also comes to us. So what can we do before we treat the patient? How can we optimize our patients for treatment? And Holger, I think you have a good presentation for this, and time is running. So Holger, the stage is yours.
Thank you guys for having me. We just noticed we have 3,000 clips made. We all together here in this room, so we can be proud of. And I'm very honored that I'm joining you. I show the audience a real good screening method to boost your AV valve departments and your case rates. So we made some slides. I have some potential conflicts to declare, and our half-catheter edge-to-edge repair program focuses on structured patient flow. We try to fill every slot along the week, so it's very important. It's kind of hard work, as you know. We have interdisciplinary collaborations with different kinds and standardized clinical pathways. We have a very focused responsibility for TEER program, which is important, not so many shoulders. We are very attainable contact persons for TEER programs, and we have a very strong patient proximity. This is a key point, I think. Our goal is to provide timely, safe, evidence-based treatment for patients with symptomatic regurgitations. So next slide. The most common asked question when people see our case rates is, where do your patients come from? How do you do what you do? So we have referrals from cardiology practices. We have other hospitals in our regional network, and we're working quite smoothly together. We have also recommendations from heart failure specialists and echocardiography labs, so we cardiac surgery assessment centers and other patients. We have a clear image-based detection. We have a systematic screening method for patients with significant MR and TR. And one point is quite important but unusual. We avoid the separation from EP from the core cardiology. We had some years with left atrial appendage focused TOE. It was kind of difficult for all of us. Also, we have an education and outreach program, quite successful, regular communications with external cardiologists and case discussions. We made patient events once a year, talking about different histories of patients and how they feel and something like that. And our in-house specialty is a very progressive PR program. We have a highly patient involvement, a close care relationship. We made some follow-up interviews along the way, and patients can get a multimedia souvenir if desired. It had a kind of advertisement effect you won't believe. The key principle is early identification of the heart failure and active communication at all times. So what we use, everyone knows it, we use the same as everyone. We look the etiology of the tricuspid regurgitation, quite important for planning and direction making. Is it a primary, is it a secondary one? And we use the Beasley scheme. It's quite good to have a predictor of a success rate. If a jet of the TR is antroceptal and you have a coadaptation gap below 7.2 millimeters, it's, as you know, success rate from 80 to 90%. It's perfect. So we love this scheme. But if it's non-anteroceptal and the gap is quite too big, I show you some cases later, it's difficult and the success rate gets lower as you can think of. So what it's an amount of work to handle so many patients. So you can imagine that we have once a week a heart team meeting, very important. We are working together with a very cooperative heart surgeon, open-minded, modern Professor Albert from Heart Center Dortmund, and we are discussing the cases, making plans of next decisions in therapy and the TEER procedure. We using the Euroscore 2 risk score and discussing the completely case with our colleagues, and this is quite interesting. The therapy decision making is, you know how it is in 2025, it's complicated. You have many options. If the etiology is quite clear and you have a secondary TR, it's always suitable for TEER. We all know that. But if the patient's young, risk score is quite low, you can also think about TTVR, or you can think about TVR, always an option, or we call it a backfall level. A difficult thing is the etiology of a pacemaker-related TR. As you know, you have many options. You can work leadless, you can remove the lead, you can displace the lead during the TEER procedure. We will see a really nice case from my colleague, Dr. Nicolai, later. But it's nothing to the primary TR. The same thing, it's very suitable for TEER, it's very suitable for TVR and TTVR. And if a case is not manageable and the patient seems to be lost, it's always a good point, the heterotropic covered valve device, it's called trick valve at the moment. I think we implanted 25 till now. It's a very, very suitable thing. I have a talk about it perhaps later. Yeah. But let's have a look. What can targeted screening make? What a difference it can make. Our own example, just have a look at the years gone by. When I was in charge in 2020, the case rate was rising. It reached all-time high in 2023, and we lost some cases, imaginable, but it's not that they lost. We treated them with the Edwards device, the numbers on the right side, and what you also can see how the learning curve is developing for each department. The intervention time, we had cases with 9, 10 minutes, 12 minutes. It's manageable and thinkable. But you also have the cases you fight with. So I'll show you a case later.
This is really impressive to see how a good team and a good concept for patient screening. At which time point? Sorry for the question at this time. At which time point you will do the TOE? Will you do the TOE within your hospital or by the referring physician?
We do it in our hospital, and we also do a follow-up after the TEER. It's quite important because we try to get some data out of it, and it worked out really fine, as you can see.
Okay, so you get the patient without TOE from your referring physicians, and you do the TOE,
right,
and also right heart cath. In every case. Yeah.
Everyone hates it, but we do it.
Okay. You cannot win much with the right heart cath. But I can stress from my own experience, it's absolutely important to have this right heart cath
and
before for the decision making, especially if you have the decision between the different devices, between TTVR, CAVI, or edge-to-edge repair. I think we can go on with this with your case.
Finally, the MACE rate. Everyone thinks, okay, TEER, what is TEER? And the MACE rate, major events, none. No one died. TEER is the most safest and most widely used method for treatment of TR, and I think we all know why, because of such a MACE rate. there's more to come. We're working on a precisely outcome analysis in progress. And now I show you some cases under the slogan, don't wait until it's torrential.
So the MACE rate, I think we have also discussed afterwards about this, because the MACE rate is really, really in experienced centers absolutely low. And we have novel technologies. They are hyping at the moment in Germany and Europe or worldwide. But this low MACE rate is really unique for the edge-to-edge repair. And I think so. We can say this is really an all-comer device. Okay.
So let's start with the first case. It's quite a unique one, a once-in-a-lifetime thing. As you can see, we have a controlled meltdown of a TR. We thought here. It's a patient in his 70s, leaking legs, ascites. We have pleural effusions. This is the TTE at arrival, quite big vena contracta of 30. We have a right ventricle quite dilated, 60 millimeters. This is the same patient after 7 days of furosemide, no reaction. So we needed a sufficient negative fluid balance. It was quite clear. We tried it with CVVH therapy. Day 1, UF rate 250, quite good downsizing to a severe TR. And remember, it was big. Second day, you have a borderline TR to moderate to severe, and then the third day, we call it filtration weekend. It's a diffuse, very low intense TR, and so we all know what this means. Proper timing is everything in these cases. It's perfect time for intervention. We referred the patient to cath lab, and as you can see, very, very good meltdown of the right ventricle. It's 45 millimeters, I think. You see the STL prolapse, and XTW is moving in right into position. Very nice recons here in 3D from Dr. Jali. And the clip is moving into position. As you can see, we're using the MPR mode to get a big independent grasp of the biggest lateral leaflet tip and pulled it together to the septal side. It fits together like a puzzle. Everything was good. And the most interesting thing in this case, I think, is not the result trace. Everyone is talking about trace, but the problem is, as you can see, the force the clip is using, and the hump is building up for a very good annuloplasty effect. So it was very, very successful, I think.
Yeah, great case. I never used the dialysis before. So what we are doing normally, if we have these larger gaps or decompensated patient, I think we can say don't treat any patient under decompensation situation. I think that this is absolutely clear. But to recompensate it, take it 2-3 days before with furosemide and something else. So my first question, in vice versa, will you treat also patients without any symptoms? So our referring physicians ask us, we have a patient with high-grade tricuspid regurgitation, good RV function, normal PA pressure, but high-grade tricuspid regurgitation, but no symptoms. So will you treat them?
It's a very good question. I think if a patient does not suffer, it's a real big problem because you can't take something from him. He will ask you later, okay, what is the difference now? So we used to get quite near to the patient, talk to him, try to get a follow-up after 3 and 6 months and see what we've got. We try to get likely conservative. It's hard for us because you get greedy, you want to treat this, but in this cases, I think you have to step back, and it takes some time for the patient. He's not ready yet.
Okay. Yeah, I agree with you, but what I fear is that we not get the right time point, that the patient is out of screening, and then after 3 years he comes back with a big right heart, torrential tricuspid regurgitation, big leg edema. What I learned over the last years that we ask always the wrong questions, to our patients. So the referring physician says to us, okay, there are patients with high-grade tricuspid regurgitation, but without any symptoms. Yeah, and I say always, do you ask the right questions? Yeah, they don't suffer in the first stage of the disease. They don't suffer under dyspnea.
Right.
They suffer on a little pressure on the stomach, under these fatigue symptoms, a little edema, a little elevated liver enzymes, a little depressed renal function, but no dyspnea at this moment. And I think this is the right time point to be in. But yeah, let's have a look at the studies in the future. Yeah, it may be that we also can be more earlier in the stage. What do you think?
Yes, I think the most important is that the patient is as recompensated as possible when you do the tricuspid screening.
Yeah.
So we never did dialysis before as a prehab as you, but it's a nice idea. We take a lot of furosemide as much as possible to get the patient dry as possible. And then we do the assessment for tricuspid repair or replacement. Yeah.
So guys, I have another case for you. It's a unique one, I must admit. Let's have a look. It's a case about a man in his 80s with a torrential TR. You can't discuss this fact away. I'll show you the pictures. It's a ridiculous big gap. We tried different things. The patient came with completely torrential TR after 1 week of furosemide. Nothing changed. Everything was big, nearly 7 centimeters, and you see the leaflets were quite wrapped backwards because of the high pressure levels in the right ventricle. So we really had to stop here and ask, what now? We break up? We try it? We try TTVR? This is a real good question we want to...
Yeah, the only thing is we know that we have an absolutely low MACE rate, so then you can try it, but you don't want to do something without any help. So, okay, this is a good question, and you should have a poll at the moment. And
how would you treat?
Yeah, how would you treat? Yeah, break up or try? You saw the images, and it's interesting. Yeah, also prehab is a question. Dialysis is a question. Before TTVR, maybe. Marcel, you have a lot of experience with TTVR also in the early stage.
But the hole looks huge. Even TTVR wouldn't tackle this problem because you have to grasp leaflets as well with TTV replacement. So it's a really difficult case you choose, and I'm very interested how you treated it, really. But I have one question. It's impressive numbers of your center. You have more than 300 TR procedures a year. And how many operators do you have to have a personal experience? You know, the patient wants to see the operator. He wants to see it before and afterwards. How do you manage it?
It's a very, very good question because at the moment it's me for the most of the patient and my head of department, PD Dr. Hippe. We share the cases. At the moment, young colleague is learning TEER in normal procedures. We started because it's a lot of work and we're growing. And so it's a difficult thing. But you know how you get clip addicted. It's a really kind of, I really like the procedure. And we share it now with a hope to grow further. Yeah.
That's also what we are seeing in our institution, that we have now. I think this will be the future, that the cardiology will be divided in 3 parts. So in the classical coronary part, with or without TAVR, the electrophysiology, and the structural part, especially where interventions for the AV valves, where you need echo and you have this big treatment options. I think this will be the future, and also in our institution we have a despite team only for AV valves. So okay, we had this poll. I'm very excited what this poll brings. Okay, so we stop the poll now, and please give us the result. Break up or try. how would you treat this? Okay. That was the wrong Paul. I'm sorry. Yeah, that was the wrong Paul. That was the Paul for another thing. But yeah, it's T-tier. It's 56%. Try it. TTVR is 11%. Then lead extraction followed by T-tier. You have no lead inserted, or is there?
No,
there's no lead, yeah, and lead extraction followed by KV, 20%. Yeah, so, yeah, 50% will do the T-tier. To be honest, I would never try this case.
Yeah.
Marcel?
Yeah, it's amazing.
It's ridiculous.
Please tell us.
It's really a thing. I can show you what we did. We read about preload limiting. Can we continue the video?
Yeah, I think you can.
I can do it.
You can go.
Yeah, we tried it, and we thought about what about preload limiting with a balloon. We used a Zipka balloon, 20 millimeters. This is a de-airing process. And the SVC was measured 29, so we have a very low dissection rate, and this is our grasping plan. What we did is we created two hemispheres, as you know it, anterior one and posterior one, and the leftover in the middle, the massive gap in the middle, we try to close with a hemispherical grasp. So the comparison, is it really anatomy changing if you just inflate a balloon? Just see the difference. We did it, and you see the sharp-edged leaflets. At the first time, we really recognized something. So we used this little time shift here, and we went in with a XTW G5. You see up above, the balloon is inflated, the clip is waiting for its grasp, and we're moving in quite low with anterior septal fusion. Very good, but the interim result was quite not this good. So we did the posterior fusion. It was quite easy, did it independent, but then the question was, is it enough? Or we closed the central gap, and we did it. It's quite difficult because you have to have such a little amount of space, and you have to dive in very targeted, and then you have to, the clip alignment is completely counterclockwise. So we did it, and we closed it, and it was traced. I think the gradient was great. Trace, I really thought about, is it really a good thing when I show such a case, because the audience may think that trace is what we are looking for after a tear. It's not. Because trace, as you know, as we know, is a burden for the right ventricle. And it was more when we really expected, but
it is absolutely fascinating. Yeah. Did you publish it?
No, not yet. But
you have to publish it. Yeah. So the balloon was in the SVC and in the IVC, two balloons or one balloon?
Yeah, we spared out the lower one balloon because we thought with the system device.
Yeah.
We close it anyway. Yeah. So we just wanted to try it, but we were so surprised that it's working so good. It was. We really didn't expect that.
Yeah. It's really impressive, yeah. But what I feared. So how was the PA pressure on this patient?
I think 41.
41. The RV function was mid reduced,
16,
So also not so a perfect case from the afterload mismatch perspective for valve replacement. Yeah. Absolutely impressive. So thank you, Holger. It was really nice presentation. So time is running. Yeah, we saw a really great case about with edge-to-edge repair in the tricuspid valve. Yeah, outstanding case. So more to the normal cases for the strategy. So if we think about valve replacement, orthotopic, heterotopic, it's most times straightforward. There's only one way. Yeah, you have the decision before, but there's only one way. But if you go for edge-to-edge repair, what is the most common procedure in tricuspid regurgitation treatment, we have always to have a strategy, yeah, where we set the first clip, where we set the second clip, yeah, and you have to be always one step ahead to think what's the next step. And Marcel is one of the most experienced interventionalists in edge-to-edge repair, and he will show us a presentation about tricuspid clipping strategies. So, Marcel.
Thank you, Philip. Yes, I have an educational case, and as you know, more than 90% of the procedures are TTVR procedures. And so I have a typical tricuspid patient for you. It's an 84 years old lady, and she has a typical disease for these patients. She has permanent AFib, and of course she has anticoagulation, no CAD, and she has a Euroscore 2 of 2.8% and a tri-score of 4. So this means a peri-operative mortality of 8%. So I think very typical, but one thing is different. She has more than 3 leaflets. And you might see it in the right-hand moving image that there's not only a septal, a posterior, and an anterior leaflet, because the posterior is divided into 2 leaflets. And you might imagine it in this image that the posterior is divided into 2 parts. And this makes clipping more difficult. Usually we try to clip anteroseptal. This is our most common strategy. Rebecca Hahn published 4 years ago this publication where she said there are just not only tricuspid valves, and those account just for 54% of patients. And the second most often etiology is the type 3B, where the posterior leaflet is divided into 2 times, as in our case, and this accounts for 32% of patients. And in a publication of our center, we showed that those morphology leads to not perfect TR reduction. As you see here in the slide, that if you have a 4-leaflet configuration, the declining in TR below grade 3 is much more seldom compared to a 3-leaflet configuration. So we have to see in a perfect way on the valve, so imaging is very important. And so my first poll is, how would you clip in this case? We have 3 options. I hope the poll is seen.
Yes, the poll is open now.
A is central, so from lateral to septal. B is anteroseptal, and C is posteroseptal. So usually we would start for anteroseptal, as you might see here on the smart screen, that we try to bring together the septal and the anterior leaflet. The second most common as a starter is the septal lateral clipping, like this here. We called it the eagle. When you bring with a big clip the lateral and the septal together, and the third option would be here, posteroseptal, to bring the leaflets together. And we ask you, what would be your option?
Yeah. So I think that's very common to have this multilobulated valve. So we love the work of Becky, but do you believe this, that if 50% is really tricuspid? So
I believe it's even more,
yeah.
Because the tricuspid, the real tricuspid is below 50%.
Yeah, it's absolutely rare. I think so. Yeah,
and really we have to look very accurate on the valve, because as many imagers know, if you go a little bit deeper, if you play with the angles in TOE, then you will see that, okay, there's a 4th or a 5th leaflet, and this makes the procedure more difficult.
Yeah, and also what we learned is that if you think, okay, this is a tricuspid valve, yeah, then you grasp septal anterior, start with this common septal anterior with this Clover technique, and then we see, oh, there is a divided septal leaflet, so that we have done more than than one leaflet. So this is, I think that's common, yeah.
And I showed a lot of transgastric images. We love to grasp in transgastric because you see the perfect anatomy, and there you can prove your concept and see if it's a good grasping. So I know, how do you do it? Transesophageal or transgastric?
So I don't like the esophageal grasping, yeah, because especially in these cases, if you have more than 3 leaflets, yeah, and you try to grasp, and we always know that if we go from a deep way from endoventricle, we go up, we try to grasp the leaflets from a deep way, yeah, then the clip turns a little bit, 10, 20 degrees, yeah. You cannot see it perfectly in fluoroscopy, you cannot see it perfect in the transesophageal view, yeah, and then you are very glad to grasp, and then you say, oh, yeah, we had the wrong leaflets. We are not septal anterior, we are septal posterior, or septal P1, P2, P3, something else. So we love to have the transgastric grasp. So how is it in your institution?
Yeah, it depends, I think. We created a kind of mixture. To evaluate the entry, it's quite important. I use the X-plane through the bullseye in transgastric view. So you see the device coming in a good shape. If not, and it's divided, there's a deviation, it's kind of a problem. We all know that. You place the clip and it's going wild and it's turning and something like that. So entry is always transgastric, then placement, and moving along the commissures, everything transgastric, but when it comes to septal grasping, we used to go upwards and have a look how far and how deep the septal is moving under the clip, because this is the key point.
Yeah, so I think you can also do it from a transgastric way. The thing is, for real life, from my experience, yeah, we have always shadowing, yeah, and especially in these cases, we have some shadowers, yeah, some patients have an artificial aortic valve, then you have this shadowing, yeah. So if you have this deep transgastric view, deep transesophageal view, I think this is very good, then you can treat the tricuspid valve like a mitral clip or like the mitral valve, yeah. But I also love to have the transgastric view, and also for screening, we are also only look for a good transgastric view. If you see it in the transgastric view, it's perfect. How is, you have experience with 3D MPR, I think so?
Yeah, but we know...
In the US, 90% are doing the procedure with 3D MPR. We have
it's a
very
less
experience.
Okay. Everyone loves MPR, yes, everyone does it, so why don't we? Yeah, we do it, but the patient has to be quite suitable for this, because if you don't see anything, the MPR won't help you.
Yes, when you have not the best imaging conditions, MPR is not better. And I like as well the X-plane, and I think transgastric imaging is good for orientation, and transesophageal imaging is very good for the trajectory of the system.
Absolutely, yeah.
We have the results.
Okay, yeah, then let's have a look at the results. The poll is closed now. How would you clip? We have 11 votes. So let's have a look at this. So, okay, the most are central, lateral septal, where is the origin of the tricuspid regurgitation. Anteroseptal is 27%, and the less is posterior septal, yeah, but there are also, guys, they start posteroseptal. Yeah, so posteroseptal, to go from posterior to anterior, has the problem that we have this shadowing if we try to grasp transgastric. So this is the only, I think, disadvantage of the transgastric grasping. So the most colleagues are going central.
The eagle grasp.
The eagle grasp. So
I love the eagle.
Okay.
Yeah, we did it. I show it on the next slide. We did it anteroseptal. One reason may be that we don't want to create shadow in the transgastric view. So we started as almost, in most of the cases, anteroseptal. And this is the grasping you see on this slide. And you see the anatomic result looks quite nice. So we could bring the leaflets very nice together. But on the next slide, you see the result. It's kind of okay, anteroseptal, if you can see it here. But posterior or central and posterior, there is still not small jet, and it is eccentric. And I always say eccentric jets are underestimated.
Yeah.
So like this here, you see it, it comes from posterior and goes down to anterior. And
You think you have changed the valve direction a little bit with this grasp? Or
it could be that we didn't bring together the right parts of the leaflet. So. Okay. It might be a bigger hole central, so we were not happy with the result. How do you think? Would you stay like this, place a second clip above, or would you say, think again?
I think out of the I think the transgastric view is perfect for to evaluate the anatomy of the valve, also to evaluate to grasp. But it is not a good thing to evaluate the result. So to evaluate the result is better to do it transesophageal, from a transesophageal way. So if it's strictly from the posterior side, maybe also eccentric, maybe that I leave it, because it's I say it's always like an angel wing. It's coming out like a fontaine out of the clip. So I think the clip is sitting good here. But
But I think it's not this. I know what you mean. It's not looking natural. Whereas there are some parts of the lower septal leaflet still moving. Kind of curious because you did a good grasp, and you see some tension in the network of the papillary muscles. You see it in the middle of the right ventricle. So I think there's something we only see the tip of the iceberg.
Yeah, I also believe that the tension was changed somehow, not in the perfect direction. And you have a question?
There is an interesting question. Yeah, there is an interesting question. Okay, you can try to deploy in every position and then choose the right one. So I think deploying in every position is not the best thing, but grasping in every position, what do you think?
I think
Triseptal anterior, triseptal posterior?
You have to be very strict to yourself and not place it and release it just because you are a cardiologist. So we should go for the best result, and the first clip is the most important. So when we place it, then we should keep in mind that the next clip should reduce the problem to moderate or less. And in this clipping position, we were not happy. So I'm right, when you're not happy, try it at another position before you release the clip, because otherwise you should remove all the system and think of another therapy option.
You are also a little bit, I think, procedure related. If the grasp was absolutely easy, then it's clear you open. If you're not clear. If you have if it took 10-15 minutes to close the gap, then you say, okay, let's go for second or third.
And you don't want to hurt the leaflet, of course.
Absolutely.
That's another question.
That's a big problem.
Okay, Marcel.
I move forward. So we decided for another position. As you see here in the left upper video, it's still transgastric. We not released the clip, but we opened it again and repositioned it to the central position. So like the most of the people voted for, the eagle position, bringing lateral and septal together. And you see, anatomically wise, it's a very good result. You see it in the left upper image. It brings the valve very good together. And when you see in the right bottom image, you have still residual TR, but it was quite less compared to the result before. So this was then our good clip result, and so we decided to release the clip there in this central position. But one disadvantage appears now, because in the left transgastric image we have bad imaging conditions afterwards, because the central clips creates shadowing. But we are happy with this clip, and we were very confident that the second clip will create a nice result, and I show you.
But I think if you look despite at the transgastric view, there may be a chance for a septal anterior one. Yeah. Normally we say, okay, there is a shadowing, but I think with our experience, you can go a little bit deeper, or I think there is.
You can play with the shadowing, how deep the probe is in.
So imaging is everything. Yeah, that's it. Yeah. So the imaging is a big part of this procedure. Okay.
So next slide, we place the second clip anterior septal, and there you can see anatomically wise in the right half of this slide, we brought the valve good together at a low gradient of 2 millimeters of mercury, and on the left bottom you see the TR result, which is quite nice. So we reduced this TR to trace or less, and so we were very happy. And I think this case shows that you have to rethink your strategy sometimes within the case, but it's very important that you have a good imager, that you have good images, and sometimes the images change from clip to clip, so it's very important to look at.
Yeah, absolutely.
And this result was sustained after 3 months, so we were very happy with this, and so this was my case.
Great case,
Thank you so much. Yeah, so we have a little time. At the moment there is no question. So I have a question. So what we have not talking about hemodynamics. Yeah, in this case, would you also think about valve replacement? So there are valve replacement systems. I know in Bonn you have much experience with different valve replacement systems. When do you think about valve replacement? When do you think about edge-to-edge? And you have experience with CAVI. Yeah, we have also experience with CAVI, with the trick valve, with the bicable system. So let's have a little discussion about this. Are there borderlines? Are there facts where we say, this is a case, we can do this, this is a case, it's absolutely not doable?
I think in this case, the hemodynamics were quite okay. So there was slightly elevated pulmonary pressures with 20 millimeter of mercury in the mean gradient, and the TAPSI was quite okay. So we could have done replacement as well, but the anatomy looked quite nice, and as we saw in your lecture, that the MACE rate is very, very, very low. So in triluminate pivotal, we had a very, very low mortality, and in all other TTVR studies as well. So I think in this case, with a small gap, I would every time go for a clipping attempt. But I have to think about when I release the first clip, I have to be sure that I reach a good result. Otherwise, I should rethink taking everything else and go to the heart team and think about.
Yeah, I know there is data to be as good as possible. Yeah, but I saw this study. Yeah, where edge to edge has to be at least grade 0 or grade 1 at the end. Yeah, and if not, then you have if it's not predictable, then you have to go for the valve replacement. But I think about especially these patients, because if we have patients like in your case where we can have a result of grade 0 or grade 1 afterwards, these are the more healthier patients than as in your case. Yeah, with your case, with this balloon, really impressive. With this balloon, I think. There normally you cannot get a result of grade 0 or grade 1 with edge-to-edge repair.
But there's no evidence in the guidelines. They say just treat it, but they don't say which therapy is better, replacement or repair. So we will see in the future. Yeah,
we will see in the future. So, but what we can say, I think from our experience, and this is what you showed, that edge-to-edge is absolutely really has nearly no side effects. Yeah, also not from a hemodynamic side. Yeah, what we learned is that valve replacement has side effects. Yeah, we have a higher MACE rate, we have a pacemaker rate. We have to keep this in mind. We don't know anything about long-term result. We don't know anything about endocarditis rates or endocarditis. Must be higher. Endocarditis, also anticoagulation rate, valve thrombosis, and something else. So I think edge-to-edge has the fixed place, if it's working, and what we are also discussing now in the last case is the RVPA coupling. Yeah, how is the afterload mismatch situation? If we have these end-stage patients, yeah, with this large right ventricle, yeah, and this high-grade, maybe high-grade pulmonary pressure, yeah, high-grade torrential tricuspid regurgitation, and we replace the valve. So I think then we will get really in a right heart decompensation situation, and also the companies say, oh, these are not the patients we want to have. So I think there is more data needed in the future. So, okay, at the moment we have no question. Though, one question at this time point to your case, I forgot it. Please explain again the balloon concept and the SVC again. Can you please explain it again? Because
you choose, or we choose balloon smaller than the measurements we made in the TOE in relation to SVC, because we were very aware of dissections in this area, because you get a very, you know what happens. It's a real life-threatening thing. So we just want to limit the flow, the preload flow. And as you can see, the spontaneous echo contrast between the leaflets wrapped around showed that there's an amount of preload hurting the valve. So we just wanted to have a closer look what happens. It was the first time for us too, I must admit, yeah. But we were really surprised how anatomy changing a little less preload is for the valve in this situation. And after, I think, 2 minutes, you saw changes. So I don't know if it's working in every case.
Yeah, that's N1.
Yeah. In one, it did. And it was life-changing for the patient, I must admit, really.
You do it under general anesthesia, your cases?
Yeah, always.
Yeah?
Yeah.
Is there any change was there any change in blood pressure or from
the patient looks
if you inflate the balloon?
The completely edema is gone, ascites.
No, during the procedure.
Blood pressure was rising up, but...
it was rising up, and at the time point you inflate the balloon. Was there any change?
We were aware of a depression of the circulation. The anesthesiologist had catecholamines in position, but nothing happened really.
Okay.
It was stable.
It was still the inferior caval vein, which was giving some fluid. So it's a very good idea. Yes. Yeah,
it's a good. What I do is to deload the patient. I have the possibility now in my cath lab to do an anti-Trendelenburg.
Wow.
Yeah, to lower the legs and raise the head.
Perfect,
yeah, and then you have, especially in these cases where you had if you had an edge-like gap, about 10 centimeters. We are not so strict with this 7 centimeters. Sometimes we have this chance for sipping, and then we start septal anterior with 1 or 2 clips, and then sometimes we close the clip. It's also if the leaflets are like this, you have no chance to bring them together. But if you have this ventricular, high-grade ventricular tricuspid regurgitation with the leaflets tethered into the ventricle, and you bring them down, I think this is a good chance. And with this anti-Trendelenburg, I think it may be good. Okay, time is running. I have a little presentation now. The last 10 minutes. So it's an 83 years old male patient with a lead-induced TR. We didn't talk about lead-induced TR. Several episodes of right heart decompensation. Underwent mitral clip, has an ICD implantation that origins the tricuspid regurgitation, chronic renal failure, aortic stents replacement, and aortic root replacement. So clearly not a patient for operation. So these are the screening images. You see here, it's high grade to massive tricuspid regurgitation, and you see the lead is lying on the septal leaflet here in the middle of the valve, so it's not common that it's in the middle, most time in the posterior position, but you see it here also in the transgastric view. Yeah, so in the transgastric view, the TR seems not to be high, yeah, so transgastric is good for grasping imaging, but not good for estimation the tricuspid regurgitation. So PA pressure was quite high, TAPSE is a little bit lower, so Euroscore, TriScore, sky high. So we have a RV-PA coupling of 0.3. So this is for us too less for valve replacement. Yeah, I have here so the pros and cons. So TTVR valve replacement, simple procedure. We mentioned it. It's straightforward. Also, CAVI, the bicable procedure, is good for, yeah, normally both procedures with perfect result. But in both procedures, we have a risk of an afterload mismatch situation because we have a bad right ventricle, high PA pressure, and if we close this valve behind, then we bring the patients sometimes really in a right heart decompensation. Yeah, T-tier is always an option, also in these patients. Yeah, we have no risk of afterload mismatch. Yeah, we have a way back. We can open the clip again if we see during the procedure that the patient will be bad, but we had the lead shadowing and the result is sometimes unpredictable. Yeah, and so the question is, and now we want to have the next poll, how would you treat? The next poll is, about how would you treat. And the next 2 minutes, I think we can talk a little bit about mechanism of lead interaction. Yeah, so this is from a brand new paper, very, very good, yeah, from the tricuspid focus group. So leaflet perforation or subvalvular damage, we don't see so often, I think so, Marcel.
Yeah, I think even more is leaflet impingement.
Yeah.
So damage and perforation I see very rarely, so I agree.
Absolutely, yeah, and then I think we have nearly no chance with edge-to-edge, yeah. Leaflet perforation for sure not, leaflet impingement a little bit more.
But and again, imaging is important in this
absolutely
case, because without proper TOE,
yeah,
you won't see it.
Yeah, absolutely. Yeah, and what also in the US is very feared is that we have afterwards. What will we do if we have an endocarditis on the lead? Yeah, we cannot remove it good. Yeah, and also, yeah, sometimes we have a little paravalvular leakage. I think also with the current TTVR system, we can also treat these patients normally very good. But yeah, what's happened if we have endocarditis on the lead? And this is, yeah, I think unsolved the problem. Yeah. Okay, so there are risk factors. So in the US, they are very strict to look for these risk factors, and then they remove the lead. What about removing the lead and TTVR afterwards? What do you think? Not TTVR, TR afterwards. What do you think?
We tried it in two patients. Surprisingly, the TR was still there. I think the changes are quite chronicle, and if the deloading of the right ventricle is failed, the dilatation still goes on, and I think it's always a mixture of things. Mm-hmm. So what we very often try is to move the lead carefully along the commissure in another position. And I had some cases we really thought, is it still the need for a clip? Mm-hmm. This amount of battering was
This is sometimes possible if there is no lead-induced TRs or lead-related TR.
Yeah, that's right. It's same for us. We removed some leads, but often the lead was not the main problem, or the problem was already there, and we couldn't remove it. The problem was removing the lead.
Yeah.
So I think the most important question is the lead the enemy, or is the lead just associated with the TR? And I have an interesting slide. We had a patient with a massive TR, and he needs a defibrillation lead. And so we thought about to place the lead where it doesn't affect the TR. And so you see it in the first 4 examples that in every position the lead causes even more TR or makes the possible clipping afterwards even more difficult. And so we saw that the best position of the lead is in this case that it's placed as posterior as possible, going through the posterior septal commissure and heading to the posterior part of the ventricle. And then we didn't affect the TR, which was massive before, and we had good space for clipping afterwards. And we clipped it afterwards, and it was a nice result. So in those cases, I recommend to place a TOE probe during the lead implantation.
Yeah, so this is interesting.
Nice
also to discuss with electrophysiologists. Yeah, sometimes to have a TOE and to look where is the lead and does the lead affect an TR. Yeah. Okay, so let's have a look at the POL. So it should be there. So how would you treat T-tier, CAVI, TTVR, lead extraction followed by T-tier, lead extraction followed by CAVI, or T-tier? So let's have a look at the POL. Okay, so the 53% will do T-tier, TTVR 12%, yeah, with a little bit risk of afterload mismatch. CAVI 0%, yeah. I think CAVI will be also a good option in this.
Yeah.
Lead extraction followed by TIR, we discussed this, yeah. Lead extraction, especially if the lead is more than 1 year inserted, then you have most time a connection with the leaflets. Lead extraction followed by CAVI, TTVR is also an option, yeah. And but with ICD leads, then subcutaneous ICD if it needs a pacing situation. So it is really hard. So T-tier is the most common option here, or our auditorium votes for T-tier, and this is exactly how we try it. Yeah. Oh, sorry, that was 1 slide too fast. So we start with a clip septal anterior. So it's also sometimes a possibility, as you mentioned, to bring the lead to the posterior situation. You see here in the grasp movie, you see that the septal leaflet is really hard to this shadowing. It's really hard to see. Yeah, this may be a good thing sometimes to go for transesophageal view, but then you have also sometimes shadowing, yeah. But at the end of this grasp loop, we love to also the transgastric grasp. At the end of the grasp loop, you see that the septal leaflet is in, and the second clip will be in a septal posterior position on the posterior side of the lead. You see it here. This is very easy to grasp, yeah. Normally in the posterior position, there is fear of some chordae or something else, but I think this is really a good thing. And so we call this the jailing technique. Yeah, you see it also in fluoroscopy. We jailed the leaflets. We jailed the lead between the two clips, and I think the result is also good.
It's fantastic.
Very good, yeah.
It's fantastic, yeah.
Yeah.
Okay, so then let's have a look at our poll. Poll is over. At our questions, are there any questions left? There are no questions left, so I think time is running. Time is nearly over. 2 minutes left. Any comments?
Yeah, amazing cases and a nice jailing or sandwich technique. So I think it's always worth a try to do it, and you have good imaging, especially if you have many leads in place. And I think tricuspid TIR is every time an option to try, and this was the best result you can get for this patient.
Absolutely.
Yeah.
Holger?
So I love Paris. Thanks for meeting you guys. It was really a pleasure. And what I think is we just have to go on because it's
Yeah.
worth it. Yeah.
Yeah, we need more data.
Yeah.
We need more
Sure.
procedures.
Yeah. Yeah.
Absolutely clear. Okay, so then let me conclude. We had a deep dive into current treatment options for the tricuspid regurgitation. We look for some really horrible cases, with a good result. We look for more common cases. We had some discussion about leads. We had some discussion about strategy. We had some discussion about TTVR, upcoming procedures and upcoming possibilities. So thanks for joining us. We have to thank Abbott, who supported this webinar. We have to thank Alexia and the entire PCR team for the work behind. Many thanks. And we have to thank you for the interaction and for joining us today. And we wish you good procedures. We wish you perfect results. We wish you good decisions for your patients. And I think it was the last webinar for this year. So we wish you happy holidays, a peaceful time with your families and friends. And from Paris to Europe, we say goodbye, au revoir und auf Wiedersehen.